Question is, should we treat bladder outlet obstruction independent on the severity of LUTS? So we have mild LUTS or moderate LUTS, and is this per se an indication for treatment? Let me show you two different types of patients. This man is 69 years of age, has lower urinary tract symptoms, an IPSS of only 12 and a quality of life of 3. Has a rather good flow of 10.8 milliliters per second, post-void residual of 80, prostate site of 40, a thick detrusor wall, and you can see a clear, stable detrusor. A compliance is good, but the patient is highly obstructed. Has a Schaefer-Fear chest C2 obstruction, also with post-void residual. So this patient has moderate LUTS with bladder outlet obstruction. Another patient who is pretty similar, 70 years of age, almost similar, but he is highly symptomatic, IPSS, and all the rest is almost identical, and has a poor quality of life. And what's the case? He has detrusor overactivity, but he has no signs of bladder outlet obstruction. So the question remains if we should treat these two patients with very similar characteristics in the same way, or should we treat him differently? The problem is that there is no clear association between symptoms, prostate size, and bladder outlet obstruction. So therefore, we have an overlap, but we have to look at these three components separately. And we cannot predict from the presence or the absence of one component the other components. So therefore, we have to evaluate each component separately. There are several possibilities, as I've shown you in my previous cases. So the question is, should we treat bladder outlet obstruction without relevant lower urinary tract symptoms? The main question is, can bladder outlet obstruction cause lower or upper urinary tract damage? If the patient is not symptomatic, mildly or moderately symptomatic, we have to look on the pathology of these components: bladder diverticulum, bladder stones, reflux, hydronephrosis, renal insufficiency, or urinary retention. So treatment of BOO is only useful if it causes damage to the upper or lower urinary tract. So what is the scientific proof that bladder outlet obstruction really causes urinary tract damage? And we have written from the ICIRS an overview article with a couple of colleagues where we had a closer look at the literature. And we found that bladder diverticula most likely are caused by increased voiding pressure. However, there's only one trial showing it, but there's no second trial. Bladder stones are also likely to be the result of bladder outlet obstruction, but it seems to be multifactorial with incomplete bladder emptying, urinary tract infections, or persistence of upper urinary tract stones in the bladder. Reflux, we don't know. We have not found a single study showing is it connected with bladder outlet obstruction. Hydronephrosis, it is possible because it's indirect via increased bladder storage pressure, low compliance, and this is associated with bladder outlet obstruction. Renal insufficiency is the same story. It's also possible. And even urinary retention is possible. There are now a couple of studies. It was at the time we did the analysis only one study, but now there are a couple of studies showing that bladder outlet obstruction is significantly associated with urinary retention. So what is the clinical data of watchful waiting versus TURP? If we don't treat these patients with bladder outlet obstruction because they are mildly or moderately symptomatic, what is the outcome? There was a fantastic study in the US, a Veterans Administration study ongoing from 1986 to 1989, so it's rather old, but still up to date. This study is not very well known, but it's a very important study. There were 556 men with a mean age of 66 years. They had a symptom score, which was not IPSS because it did not exist at that time, a symptom score of 15, a PVR of 110, and a Qmax average on 12 milliliters per second. 280 men went into the surgery group, 276 men went into watchful waiting group. The TURP in this group was done until the capsule, and the medium resected volume was 14 grams. And they showed the results after 3 years. And you can see the surgery group and the watchful waiting group. And there are significant differences with regard to symptom score, PVR, Qmax, quality of life, and activities of daily living. So there seems to be a benefit of surgery of the prostate compared to watchful waiting. Even more interesting is the follow-up investigation, a sub-analysis of this study. And they compared the patients who were randomized in the TURP group directly after diagnosis and compared those with delayed TURP. These were patients initially in the watchful waiting groups. Then they stepped over to TURP because of symptom increase. And it was a total amount of 27% of the men in the watchful waiting group. The high bother was associated with crossover from watchful waiting to TURP. Then they had a look after 60 months, so it's 5 years, and compared the parameters of immediate TURP to these people who were delayed, who were resected in a delayed fashion. There was a significant difference in symptom score change, significant change in Qmax, significant change in post-void residual. However, the bother score was not different. So the result of the study is that immediate TURP delivers more favorable outcomes, and there's less time for bladder damage compared to those patients who were resected much later. So untreated BOO seems to harm the bladder morphology. Therefore, we have worse outcome after delayed treatment. So what can we do if we have a patient without LUTS or mild LUTS and bladder outlet obstruction? I think the general reflex of urologists is to prescribe an alpha blocker or 5-alpha reductase inhibitor. And we have done for the guidelines in Germany analysis, what is now the difference between pre and past treatment. Pre-treatment, PDAT Qmax is the blue point, the blue dot, and after treatment, these are median values, is the red square. And you can see that with the drug therapy, we hardly have any change in PDAT Qmax, no difference or almost no difference in obstruction grade. So we can summarize, drugs only treat symptomatically, but there's no major influence on bladder outlet obstruction. If we want to reduce bladder outlet obstruction, then we have to do an operation, and these are the operations so we can show there's always a significant decrease in the voiding pressures. So now we have a diagnostic dilemma. We have a patient that is obstructed, but the patient, if he's not symptomatic, he will most probably reject an immediate operation, what would be useful according to the pathophysiology. So what is my strategy to treat these patients? First, careful evaluations of urinary tract symptoms, prostate volume, and bladder outlet obstruction. And then if we have BOO, we are counseling the patient with regard to possible complications. Immediate TURP is mostly not feasible, but in those patients who are unwilling to undergo prostate operation at the time of diagnosis, we have to do a careful re-evaluation with regards to LUTS, quality of life, prostate volume, bladder outlet obstruction, but also with lab, especially kidney function and imaging of the upper or lower urinary tract. That's it. Thank you very much. And I hope you understood a little bit.
Thank you, Matthias. So let me do a question. You present medical treatment non-decrease bladder pressure, the detusal pressure, non-increase the flow, very minimal. So your advice probably don't insist in medical treatment. It's better to perform our surgical treatment in some case.
Well, the patient has to be counseled. You have to tell the patient what will happen if we do not treat obstruction, especially if it's a severe obstruction. He is most likely not willing to undergo surgery because it doesn't have severe symptoms and quality of life is not high enough. But in these cases, I would recommend to follow up the patient carefully. Don't make a re-evaluation after 1 year, maybe after 3 and 6 months. It's a better time. So we really have to look on the individual components of the BPH disease. We have to look on prostate volume. We have to look on obstruction, and we have to look on LUTS and quality of life, and have to decide together with the patient what we're going to do.
Okay, perfect. We have more one question. Professor Palmer, please.
Thank you. Very nice presentation, but patients come to us because the symptoms are bothering them. And I feel very difficult to offer surgical treatment for a patient with a low symptom. And because we have no evidence that performing TURP or whatever you decide to do for relieving bladder outlet obstruction in this subset of patients will prevent some bladder damage later on. So that's the point. And I saw the way you handle this situation, but here it's very difficult to offer surgery for a patient with low score symptoms.
Yes, Professor Palmer, that's exactly the same in Germany. It's almost impossible. We have to be aware that patients without symptoms or mild symptoms usually don't show up. It doesn't mean that these patients still exist. Huh? It means these patients still exist, but they are not under control and not under treatment. So we usually see the mildly symptomatic patients, so IPSS 8 to 19 or even more. And if there are only mild symptoms, I have to give the patient the advice, and I have to counsel the patient. I have to tell the patient what's going to happen if he's not careful, if he's not following up. Of course, I offer surgery, but almost everybody rejects. It's almost impossible to make surgery with somebody who's not symptomatic or mildly, moderately symptomatic. So follow the patient up closely, and make reappointments after 3 or 6 months and not after 1 year or 2 years, and some urologists do it after 3 years. That's certainly too long.